Good evening, everyone. I'm Dr. Ankit Misri, and behalf of Intas, it's my honor to welcome you all in the 35th episode of our Endocrine Talk Show series. And today we will be discussing an evolving and insightful topic, which is about the technology in diabetic care, physician's primer. Before we begin, I'm very delighted to welcome our moderator for today, Dr. Subhankar Chaudhary, sir. Dr. Chaudhary currently serving as a medical as a department of the diabetes and endocrinology at medical super specialty hospital Kolkata. Now I am invite Dr. Subhankar sir to introduce our eminent panel member. Over to you, sir.
Thank you very much, and a warm welcome to all our audience participants from all across the country. And of course, a warm welcome to our panelists who are the key players in this program. So, can we go on to the next slide? So, we have with us luminaries from across the country. We have Professor Rakesh Sahai. Of course, none of them need detailed introduction, so maybe a one-liner or two-liner will suffice for each of them. So he's Professor of Endocrinology, Professor Rakesh Sahai, Osmania Medical College in Hyderabad, and he has had all the top positions in different professional bodies in our country. Has been the president of the SAFES, South Asian Federation of Endocrine Societies 2023 to 25, and so on and so forth, and has numerous publications and is a coveted, much sought after speaker in various national and international meetings. We also have with us this evening, delighted to have Professor Ajitesh Roy, who heads the Department of Endocrinology at the Vivekananda Institute of Medical Sciences, Kolkata. And he has a keen interest right from his DM days in thyroid-associated ophthalmopathy. And it's wonderful to see that he's carrying on the work forward in a much bigger way. And he's also interested in osteoporosis in pediatric individuals. We have with us this evening Dr. Sachin Mittal. I'm sure he has joined or will join shortly.
Yes,
Who is he's joined? Yeah, great. He's a senior consultant endocrinologist associated with the Fortis Hospital in Mohali. And we also have Dr. Vaishali Deshmukh, who is assistant professor in endocrinology at Sassoon General Hospital and BJ Medical College in Pune. So with these, he's also consultant and head of endocrinology at Dinanath Mangeshkar and Deshmukh clinics in Pune. So with these, we delve into the topic, the subject this evening, that is technology, which is, of course, ruling all across. And I saw a quote from Elon Musk the other day that he's suggesting that we will not need any doctors anymore. Everything will be done through technology. I don't know whether that day is coming soon or whether that's a good news. I'm not sure. But let's deal in the present and maybe the immediate future. So technology in diabetes, we have been talking about it. We're gradually, the technology of the yesteryear is today is something, it's bread and butter. We know, we do not think of it as technology possibly. For example, doing blood glucose at home, that itself is a technology, the self-monitoring of blood glucose. But we shall not talk about those, the very basic things. So we first would like to have the wisdom of Professor Rakesh Sahai, because amongst the four this evening, he is possibly the senior most. So we have been treating diabetes, and one of the important components of treatment of diabetes, especially because it's a lifelong disease, is to educate the patient, is to have a close rapport with the patient and the family. So, what do you think is more important in long-term management? Is it the person-to-person equation, or is it the technology-driven, uh, whatever the technology that's more important? Please
Very,
unmute.
very,
Yes.
yeah. Thank you, sir. Very interesting point that you raised is the importance of technology versus the personal touch of the physician, or rather the personal communication of the physician with the patient with diabetes. Because we know from the times of Jocelyn, who said that the person who knows about diabetes the most lives longer. So the person diabetic who knows about his disease lives longer, and therefore it's very important in diabetes that we all spend a lot of time explaining to our patients about the various aspects of diabetes, various aspects of treatment of diabetes, and also the monitoring of diabetes, which is very important. And unless the patients realize that, they are never able to achieve good control and prevent complications. So I think nowadays what has happened is the technology has come in different ways. It has come in terms of educating the patients also. We are able to use technology. We are able to send them videos, or we are able to send them information on their mobile phones, and we are happy that we have been able to communicate that information. But many of times what we see is that the uptake of that information may not be as much as it is when you're giving them on a one-to-one basis, or when many of us conduct these group sessions with diabetes, and that actually gives them a lot of insights and a lot of information, which they may not actually pick up when they are actually looking at videos or looking at information coming to them on their mobile phones. Although these are helpful, but I think doing it, the endocrinologist or diabetologist or physician doing it themselves is actually very I would say much more effective than the amount of information that can be passed on by this. So I would still feel that it is the personal touch of the physician which has more influence on educating the patient more than what the information. And also what I would feel is that with the foundation that is laid on education, with the by the personal communication of the doctor, I think the all the digital technologies can add on to it, but they can never replace that. That's my take.
Right. So the point I'm sure Dr. Rakesh Shah has made amply clear is that technology has to be there, and possibly will add on, but the person-to-person touch is also important, which is encouraging, that we are not made redundant immediately. Uh, but of course, as you correctly pointed out, that a lot of information can be provided possibly better through technology. Right. So I would suggest that anyone in the audience this evening, if you have a question, please put it in the chat box, and I'll try and direct it to the appropriate person, so that you have your answers to the burning questions that you may be carrying with you. So we will try and look at a few different aspects of technology that are already in use or likely to be used in the near future. One of which is continuous glucose monitoring. So this has come in a fairly big way in recent times. So can I ask Dr. Sachin Mittal, a very good evening to you.
Good evening,
Uh,
sir. Good evening.
yeah.
Good evening,
So
everyone.
do you think that CGM is being underutilized? It should be more used much more widely. And if most, I mean, we have also got to be realistic that every patient cannot use CGM. Which are the ones that you think should be the ones to be recommended strongly to go for CGM?
Right, sir. So yes, the short answer is yes, the CGM should be used because, it does give a lot of information, which is more than a point of care reading. But yes, there are some limitations, especially the limitations around the cost, the access, and the capability of the patients. But wherever it is used, provided all these factors are taken into consideration, it definitely improves glycemic outcomes. It definitely also improves the safety in terms of, picking up many patients with hypoglycemia and sometimes unrecognized hypoglycemia and hypoglycemia unawareness. And that is exactly where the answer as to where, which patient group will be most beneficial. So, first patient group, which actually first of all comes into mind, and obviously type 1 diabetes. The more, type 1 diabetes patients are using it, it has been shown that it improves care over a period of time, right? Especially those with frequent hypos, frequent hypers, brittle diabetes, hypoglycemia unawareness. Even in type 2 diabetes, those who are on multiple daily injections, those patients, definitely it is helpful. Hypoglycemia unawareness, a condition where it is definitely helpful. Currently, we have been using it quite a lot in patients with GDM on multiple shots of insulin. And there also, since you are trying to do a multiple times a day, the number of the ease of monitoring also becomes there. Plus, it also gives a lot of information as to, the type of food and the fluctuations with food. And a lot of people, make a lot of adjustments on their food basis of the, readings, because traditionally people have been checking, say, 2 hours after a food, right? But many times the peak is coming like, say, 45 minutes, 1 hour, or 55 minutes, or 1.5 hours there, depending on the type of food. So that insight that develops after the patient has put a sensor and a CGM is there, that is very valuable. So that's how, it's just trying to tell the patients that what you measure gets treated. What you're not measuring is not going to get treated. So it's basically an enhanced kind of monitoring, which gives you a more than an absolute value, a trend, and a lot of information beyond just a single point glucose reading. And of course, as you rightly highlighted, the cost and the access is a big issue.
Yeah. So if I got you correct, so type 1 diabetes, yes, there's a strong recommendation. You talked about hypoglycemia unawareness. Yes, that's a great area where it can help us. You also mentioned gestational diabetes, where you've been using. Everyone has been using possibly, but possibly, if you look at official recommendations, still the recommendation for use in pregnancy is less strong than in other areas, possibly because we do not yet have enough data, outcome data related to that. And my
Right, sir. Right.
biggest issue is, what do we do with that wealth of data? Every 5 minutes, you have a glucose level. What do we do with that data? And can I ask Dr. Vaishali, you are a busy practitioner, but there'll be so many other, even more busy physicians out there who are hopefully have hooked on to this evening's program. So how do they quickly make sense of a CGM data? Patient would have done with great care and cost, and then the physician doesn't even look at it. So how do you quickly, smartly look at the data and get the right sort of interpretation?
Yes, I think that is a very relevant question when we are using technology. And I'm glad that Intas has taken this topic for today and invited me here with all the eminent faculty here. So I think that when we are seeing a CGMS data, there are three important aspects that I look into my practice, because it is difficult to spare a lot of time in interpreting reports if you're not very well trained at it. So three things which I commonly look at is the time in range. The time in range is that the 3 bars that you get in the CGM group, it tells you around how much time the person has been in well controlled state of sugars. So effectively, the time in range out of the 14 days, if it has been more than 70%, that is taken as a on an average better control. And second important is the time below range. So time below range, how many times the patient has been in hypoglycemia. That is, these are the two relevant information which I look at first. Second important is the pattern in which it comes. So how much of glycemic variability it has, how much of smoothness the graph has over different periods of the day and also between the days. So we all know that CGMS is looked over 14-day stretch or 7-day stretch, and that stretch effectively averages out in that graph. So I can actually predict the how the sugars are rising for that particular patient during the lunch hours, during the breakfast hours and the dinner hours. So there is a set pattern which I can identify. It can help me make my decisions on alteration of insulin dosages. It also can help me in change in my treatment protocols. It can also tell me how a person behaves on sick days, how a person behaves on normal days, what happens when he feasts or when he fasts, or when he is having hypoglycemia, is there a rebound hyperglycemia. So a lot of information comes from the patterns. And third important point is that effectively when we are monitoring our patients, when there is a increase in the time in range, so every 10% increase in the time in range corresponds to nearly 0.5% HbA1c reduction. I think that's a very important indication. So we have a lot of patients of type 1 and those with high glycemic variability who just come with a 3 monthly CGMS record and a HbA1c, and you can easily correlate that and see that as the time in range is increasing, the HbA1c is also improving correspondingly. Of course, we need to bear in mind the drawbacks and the fallacies of CGM while interpreting these, but I think a lot of problems can be prevented with the
Right.
CGMS
So
monitoring.
yeah. So Vaishali, so you pointed out that the TIR, the time in range, which you suggest should be 70% or above. You want the time below range. So what
So
would you be looking at?
I expect it to be something below 5%. So
Right.
anything above 5%, I'm not very happy with, and I'm
Okay.
scared rather that this person is going to get into hypoglycemic complications. So we try and keep them as minimal as
Right.
possible.
Do you also look at something called GMI? Does it help you? Does it glucose management indicator?
Yeah, so glucose management indicator, we have some idea about overinsulinization and how the glucose responds to a particular mode of therapy. So this, I think, we do get an idea in terms of overinsulinization or the Dawn's phenomenon or the Somiogi's phenomenon as a response to this. But I
Right.
think the major gross evaluation is based on these three parameters that on an average, the AGP level, the average glucose profile of these patients
Yeah.
matches with the
Absolutely.
HbA1c.
Yeah, in
Right.
fact,
Yeah.
the GMI is now actually added as a indicator of the what used to be called as the estimated HbA1c is now called as the GMI,
Yes.
because it
Yeah.
gives an idea about what has happened during those 14 days, how much was the average
Yeah.
That's right.
sugar. It may not actually correspond with the
Yeah.
HbA1c.
And so
That's why this new
that
term has come in.
yes, and that also brings in a problem because the patient may be carrying CGM data, which
And
gives
he'll be
you
having
a
HbA1c report
GMI,
with
which is 7%, but the HbA1c shows
still
8%, or
9%,
it may be
Correct.
showing
8%.
6%. So there's conflict, and then they want to know what is this then. So those issues will be there. But uh, you did say that there are some issues, problems, fallacies, etc. So Dr. Rahul, therefore, has actually asked the question: what are the common pitfalls or misinterpretations you see when physicians start using CGM data in routine practice? Dr. Ajitesh, would you like to answer Dr. Rahul?
I think Dr. Boishali will give the answer just now.
Okay, Vaishali. Yeah,
Okay, so basically, whenever we are relying on the technology, we need to be aware of the robustness of the technology. So you have different modalities of CGMS. So it is based on sensing of the glucose through various fluids, and the sensor, you can say efficacy, is going to change based on various parameters like the presence of edema, presence of dehydration, presence of hypotension, then the sensor sensitivity and coefficient of variation. So I think there are a lot of parameters which we don't know at our you can say scientific level, but it's more at the physical level, rather the instrumental levels that we need to be bearing in mind. I've seen this happening in practice, that patient has come to the hospital with sugar of say 35 on the CGM, and when it was checked actually in the lab it was normal. So patient is really scared when there are a lot of discrepancies. So I think we need to rely on our acumen, our clinical judgment, our evaluation with the corresponding glucose, and also we also tell our CGM patients to check it intermittently with a glucometer also, because we need this assurance that we are doing the right monitoring when we are doing
yeah.
CGM. So
Yeah. So that's one point that I have also noticed, and I quickly asked the opinion of the other three panelists also, that uh, you tend to get a sort of false pickup of hypoglycemia with the CGMs. Is that what you also notice?
Sir, one important point, a
Yeah.
few data came
Mm.
recently that a few CGM machines, I do not know whether it is with the liver or
Libre 3.
Medtronics, but
Mm.
in few machines they showed um, maybe bigger data, particularly when patient is taking paracetamol, acetaminophen, mannitol, something like that, hydroxyurea. So in this meantime, the blood sugar level may be fine with the CBG, with the SMBG, but in CGMS, you will see there are very bigger data is coming now. So
Okay.
whenever you will see maybe in the 7 days chart or 14 days chart, and whenever you will see the patient, the blood glucose is actually varying in a particular time, you have to take proper drug history also. This is also few new data are coming now.
Okay.
Tetracycline,
Drugs.
we can give this
Okay.
kind of a wrong.
Right. So
Very
of these, possibly paracetamol is the most common thing that any
yes,
patient could be taking. The others are
exactly.
less common. Yeah. So because you raised the question of different CGM, so can I ask you what are the different CGM uh, technologies or systems available to us in a country now, and how do you compare them? Does one score above the other, or they are similar?
So there are many systems are now, but usually we are dealing with this freestyle liver 3 or a Medtronic Simplera, but mostly we are dealing with the freestyle liver 3, and they are more or less uh, uh, comparable. But if we go through our experience, maybe liver 3 are the most important one. But in the higher range of glucose, I think liver 3 has some special edge. On the other hand, the Simplera, they actually showed good response in the lower range of blood glucose. So we
So
have very little amount of experience regarding this, but I think there may be some variation in the upper range and in the lower range with some machines, and but uh, the whenever a patient is wearing CGM in the arm, probably they are showing good response to the blood glucose. Sometimes, in particular in the infant, you have to wear in the maybe you have to put the CGM machines in the belly or in the abdomen. In that cases, you may see some amount of instability, but um, otherwise all the machines are more or less fine. In this background,
right,
we can say one important parameter is the MARD. I just learned a few days back. It is the mean absolute relative difference. That means you have to compare with the CGM data along with blood glucose data. If the MARD is low, that means the difference is low. So lowest MARD probably in India at this present moment is with the liver 3. So I think if we go through liver 3, that
right.
will be beneficial
Okay,
for us.
Yeah, just to
okay.
add to that, sir, since you were
Yes.
asking about all the different systems that are available,
Mm.
I would just like to summarize by saying that the most common, as Ajitesh has mentioned, is Freestyle Libre. 2, I think, is available in India as yet. We still have
Yeah,
are waiting the 3, and
yeah,
then we have this Medtronics device, which is a 7-day
yeah.
device. It is mostly used along with the pumps, tagged onto the pumps nowadays. And the third one is that we also have some new ones which have come in
There's a
recently. Sinocare is one, and then
yeah
there's something called
Chinese one. Yeah,
Tracky, some Chinese, and one
Siswell.
and
Singapore
British
model has also
UK.
come.
Yeah, yeah.
Yeah, UK one also has come called Tracky, and one Beto device is there. So these are
Probably
new
the
ones.
cost will also go down.
Yeah, cost is likely to go down. So we are going to have some exciting time ahead with many of them available. But as Sir has highlighted, that I think one of the major things that we have to keep in mind is that when we are seeing lower values, we have to cross-check it with the glucometer, because they tend to underreport, I mean, give a lower value sometimes when you're going in the
Sometimes,
lower range.
yeah.
With the interstitial fluid that we are looking at, one is that they give a lower range, and the second thing is that there's a delay between the recording on the CGM versus the glucometer. So that is one point that has to be kept in mind, and when we are interpreting the readings, I think these are points that need to be kept in mind.
Right. We could possibly go on and on with CGM, but we have to take a question from Dr. Avinash. So maybe Sachin, would you take it? Are
Yes, sir.
intermittently scanned CGM systems sufficient for most patients, or is real-time CGM clearly superior?
So good question. So intermittently scanned CGMs actually, so most of the likes are currently Libre 2, right? Let's take an example of the most common what is used. So typically you have to scan it at least once in every 8 hours. Otherwise you have a break of the data. So what happens is, say if you have scanned say at 8 in the morning, then you need to have another scan done at least by 4 in the afternoon. Otherwise there will be a lack of the data and you lose the previous data. So when you do an intermittent scanning, you can look at the previous data and then you can actually extrapolate that data and correlate with that. So I think that is something which is sufficient practically in most of the situations, because you're not trying to take an action minute by minute based on the real-time data. There is some lag which is there, but when we are interpreting the report, we are actually looking at a bigger picture, as Dr. Vaishali highlighted, that there are some things which are actually we are looking at. We are looking at time in range. I'm also looking at daily patterns, because most of the times we see that certain times of the day, certain patients tend to have a spike, which tells us a lot about their meal patterns. And if the patient is on insulin, that tells us where to put a higher amount of bolus dose at that point of time, or maybe we need to put an AGI at that point of time, or maybe we need to split the meal at that point of time. That is something which it gives us. So, I think that is how probably I would interpret the CGM, and I would take a call on that. And yes, as other panelists also have highlighted, the lows is a very common problem. I personally have seen is that even higher, sometimes the accuracy is not really there. So
Yeah, that's what. Yeah.
the most valid range actually is somewhere between say 90, 100 to 250 odd, and more higher and more lowers. And additionally, interpreting overnight readings also becomes a challenge, because sometimes the patient is sleeping on that sum. And there is something called as compression lows. Compression lows is basically the arm is getting compressed, and that circulation at that point of time, the glucose is not there at that point of time. So many times it's interpreted as low, but it is actually not a low.
Okay. That's interesting. Yeah. Okay. And so in order to make them so theoretically you could do away with self-monitoring of glucose, except those intermittent ones, to have more confidence on the CGM data, and you could do away with the HbA1c. Can we,
So
Vaishali? So shall we do away and just depend on
I don't
CGM?
think, sir. I just think that CGMS is a added aid to our diagnosis and accuracy of glycemic control. I don't think it would replace HbA1c. It will just add on to the additional finesse of the management of glycemic control.
Okay. And so in order to be actually effective and provide all the data, it needs to be worn continuously. So, is any of your patient on CGM 24/7, 30 months, and 365 days?
So actually, quite a few of my pregnant women plan to do it for shorter durations for two
Yeah. Oh,
reasons, because they have more frequent follow-ups. And
yeah.
secondly, we have seen that cost becomes an issue when patient is spending out of the pocket.
Mm.
So the cost is much lesser with 3 days and 5 days. So I think in real world, even doing it for 5 to 7 days gives a good information rather than waiting for 14 days. Of course, there are a lot of facilities and free helps and free CGM is done in the current scenario, but I think 5 to 7 days gives a fair, roughly good idea about the glycemic status of the patient.
Yeah,
Sir,
but
I
unless
don't
it's
know.
repeatedly, yeah, yes, Ajitesh.
It's my my take on this. in point that particularly in our country, pancreatic diabetes, they're extremely brittle. Few patients they're stable, but most of the patients we do see highs and lows often. So we are actually in a mess how to control blood glucose level at that time. And sometimes what happened, in spite of having uh, normal postprandial glucose, sometimes patient may present with very high hemoglobin A1C, and on the other hand, sometimes blood glucose level is high, but the HbA1c is coming low. So particularly in that background, we did few CGMS where the actually the graph are absolutely erratic and bizarre. So I do not know, but it is in my opinion, particularly in FCPD patient in our country, where the glycemic status is extremely bad.
Mm.
Probably, if we go for CGM at least for 5 days or 7 days, maybe we can get some information regarding the food pattern or
Yeah,
regarding the highs and lows, the
yeah,
particular timings.
right. So many a time, my feeling is a CGM then needs to have something to correct the minute to minute fluctuations, and which is possible possibly only with an infusion pump, a
Ah,
continuous insulin pump. But anyway, so we shall not get dragged into CGM only. We have other things to discuss as well. One of which is a smart insulin pen, Dr. Rakesh Sahai. So we have been hearing about this. We know it's available abroad. So is it available in our country, or is it likely to be available in the near future?
The smart pens are actually basically
So what are
devices.
they? What are they?
Yeah, yeah,
What are they
yeah.
smart?
So,
Yeah.
yeah, we are all aware of the pens, the insulin pens, which make the use of insulin very convenient for our patients. Patients are able to carry the insulin along with them, and they're able to take it, particularly for our type 1 diabetics, even type 2 diabetics. When they're traveling, they are going, even those who are on just the basal insulin, once a day insulin also, they find the pen much more comfortable because they can carry it along with them when they are going out and all that. So, so now the next step in the pen is the smart pen. The smart pen basically is helpful in some sets of people like like small children who are not very sure of whether they've taken the dose or not. Their parents want to monitor that,
So
so they
so
may not.
what are they? These pens
Yeah,
smart
yeah.
about?
So
So what?
basically, yeah, basically these pens have a app to which they're connected, digitally connected, and they can track the doses, the dose that has been delivered through the pen, that can be tracked, and through the app, the dosing over the whole month or dosing period over a period of time, along with the glucose values being charted on the app. So these are the advantages of the smart pen, that it can track the insulin doses which have been delivered. It can help in planning out doses also in certain situations. And but what I practically see use is that in some people who are forgetful and who are not sure whether they've taken a dose on a particular time, so they'll be able to track that their dose has actually been taken. And then in young children who are actually independently taking their insulin, their parents may want to really know. Sometimes they're not sure whether if they're having high glucose values, whether they are actually taking the dose, or sometimes misinterpreting the dose or doing it purposefully also. Sometimes these children do it to sort of get their glucose levels high and get a little more attention and all that. So those can be many issues there. So I think in all these situations it helps in tracking the insulin dose, and they can sync with the apps and provide this information which can be downloaded. So those are the utilities of
Right.
the smart pen. And I'm not very sure, I've not used smart pens myself, but I'm told that this NovoPen, we are using NovoPen 4. The NovoPen 6 is a smart pen version, I believe. So
Yeah.
I'm hopeful that it should be introduced very soon in our country. I'm not aware if any of the other panelists are using it. And then we have
No.
NovoPen Eco Plus is another device which has that. And then Medtronics also has one smart pen called the InPen. Uh, and so these pens are likely to be introduced soon in our country, and I think they are going to make it very helpful in some of these people who are going to benefit from that.
My understanding is the smart pens are available, but at least for Novo, I'm told that they are not bringing in because it will be hugely costly, and most patients in our country will not be prepared to bear that extra cost. So let's get ahead beyond smart pens. What about insulin pumps? What about automated insulin delivery? Sachin, would you
Yes, sir.
quickly tell us
Yes,
about
sir.
it?
So automated insulin delivery system is, a closest thing to an artificial pancreas that what we currently have. So to understand that, just imagine that there is a device for delivery of insulin. That's what we call as insulin pump, right? That's a device like a pager for those who do not know it. Many of the doctors have already used it, right? So that cartridge of the insulin pump, usually it's an analog insulin, which is short acting or ultra short acting. Any analog insulin which is short acting or ultra short acting gets into that pager like device, and that pager like device is connected with a tubing, and the tubing is connected with a very small cannula which goes into the patient's skin, and that's what is delivering the insulin. That's why it's pumping the insulin. That's why it's called as insulin pump, right? Now when you have that traditional insulin pump, with that insulin pump, you can do a lot of things. You can fix an early insulin dose. You can do different types of bolus patterns as per the meal of the patient. You can do a dual wave, square wave bolus, number of things, right? Now, that insulin pump is a delivery device. With automated insulin delivery, you want something automated, which basically means that automated to what? Automated to glucose levels, right? How do you automate to glucose levels? You put a sensor which talks with that device. So there is a sensor which is talking with that device, and that device is actually acting on that. Now that device cannot act on that on its own. It needs something in between. That something in between is the software. That's the algorithm, as they call it, right? Now what happens is this sensor is sending a data. The data is being interpreted by this algorithm as a high glucose reading or a low glucose reading, and that based on that, this algorithm is designing and giving a command to that pump. Okay, an additional amount of insulin to be given, or an additional correction bolus to be given, or an additional thing to be given. This is called as a hybrid closed loop. A fully closed loop is something like an artificial pancreas. Why hybrid? Because the pump or the sensor or nobody is aware what I'm gonna eat if I'm having that pump, right? That I know that I'm having that paratha, or I'm having that biryani or whatever, and I still need to carb my counts. I still need to know how much is my insulin sensitivity factor, my insulin carb ratio. Based on that, I need to calculate my bolus, and I need to take my bolus. So that bolus part I need to do myself. That's not automated. That's why it's a hybrid closed loop. So it's a hybrid between a closed loop and a manual thing. This is closest to an artificial pancreas that we have as of yet, right? A closed loop would be actually a dream thing, but it actually improves a lot of outcomes. Like some of my patients who have gone from a manual pump to a hybrid closed loop pump, their care has actually improved beautifully well, right? Because the bolus component, the pump actually understands the patient's own glucose phenomena in a manner. That's why you never get a trial of that particular pump, the patient's own glucose component in a manner. And over a period of time, your bolus starts getting adjusted. And according to that, that algorithm reads that, okay, this particular person needs this bolus at this time of the day as per his or her human physiology, right? And then you do a the basal component, sorry. Then you do the bolus component based on the meal time, and what is left is basically a carb counting, which currently a lot of technology can do it, right? So with technology, you can do a beautiful amount of carb counting. You just need to take a picture of the food, upload into an AI app, and that app will tell you what is the kind of carbohydrate it is there, right? You need to know what is my insulin sensitivity factor and what the carb ratio I'm using, and then that's it. So I think that's
Right.
what
So
hybrid closed loop or automated insulin deliveries.
sounds fantastic. So we have Dr. Abhijit asking, uh, technology-driven diabetes care is markedly different between urban and rural India. How can we bridge this gap? Who would like to answer? Of course. Uh,
I think,
mm, yeah.
sir, I'll just give it a try. And
Yes.
I think the good thing is that in every nook and corner of the country, there is a smartphone available. And it's not so expensive currently. The data is not so expensive currently. Fortunately, India is the country where, that kind of the data is cheapest all over the world actually, right? So that issue is sorted out. The device and the infrastructure issue is getting sorted out even more in the future. What is left is to reach to that particular patient in a vernacular language, in the manner he or she can understand. A lot of doctors, think of those things in the manner they have been taught. Our understandings of the disease is very much driven by the books we have read, right? But patients, at the end of a full consultation, patient will say, "Saab kya kha sakte hain hum?" Right? So patients' concerns are very different. So, taking it in a democratizing way, it's almost like democratizing the information, and taking it in a way where the patient will understand in a very, very basic terms is what is will improve it. Trying to do one thing at a time. So you understand uh, what kind of a bandwidth the patient has. If the patient doesn't have that kind of a bandwidth to get into technology and everything, there's no point in talking about it. Stick to the basics. But if somebody has that kind of a bandwidth where he or she can use it, then you can use it. Otherwise, you can make it simplify for them. Even WhatsApp is a new technology compared to what I was doing during my MBBS days, right? So simplify it. Tell the patient, record it on a paper. If you cannot chart it on an app, record it on a paper, click a picture and send it to a care team. That's also use of technology, but in a very simplified manner, in the manner that old person also will understand, right?
Right.
And
Yeah.
I think doing it in vernacular language for every simple thing, explaining it and giving it to your patients is something very, very important, which can help it.
Right.
I think the
Uh,
important point that Sachin has made is that the use of technology is different for different people. I mean, for some you
Yes.
may use the AIDs, for some it's just the
yeah.
WhatsApp which may help. So it is technology is certainly going to help, but in every patient. But what to be used in every patient is to be decided by us.
Right. So can I
I think,
quickly
sir,
ask? Yes.
yeah,
Yes.
just
Ajit.
step by step, if we go through the initially, we have to control blood glucose, particularly if we consider rural population, we have to gain confidence of a particular patient. So if we discuss properly, initially we control with the insulin, maybe in case of type 1 diabetes, and then we will ask, as Dr. Sachin already said, if we ask for SMBG chart and then send to me, then we discuss. Then again, if we consider that yes, we can get a proper response if you go for CGM, then he or she will understand that yes,
Okay. So straight away, don't go to the highest
he is
technology.
actually trying, or she is actually trying to improve my blood glucose control.
Right.
So, yes, and this is the reason why, and so we have to gain confidence from.
Absolutely. Absolutely. And can I ask you? So Dr. Sachin has given us a wonderful dream world sort of picture of the automated insulin delivery. So, Ajitesh, so what is available today? What is the best that is available today in our country, which are likely to come in future in terms of automated insulin delivery?
So, to me, actually, insulin pump device still I am practiced in Kolkata and also in the rural part of the Bengal. To me, I hardly counter when I gave only one or two pump maybe in last 10 years practice,
Right. Yeah.
because in the initial time, whenever I ask a patient to take insulin pump, they actually afraid about the initial cost.
Yeah.
To me,
Okay. So let's can we ask someone else amongst our panelists who would like to comment as to what's the
So
latest? Yes.
yeah.
Yes, Vaishali.
So in terms of insulin pump, what I've seen is that there is a difference between literacy, geography, and education. So I think educated patients on pumps make a lot of difference. So it is irrespective of whether they are urban or rural, and irrespective of their financial status, their educational status about the pump and the delivery device is what really matters. I have a lot
So
of patients.
that's a very important point. I just wish to buttress the point that it's not the degree that person holds,
That's
but education about the pump or interest that that person takes in the pump. That's the most important. Yes, please go ahead.
So, and I have seen in my practice, I have patients coming from the remotest village, but they are well educated on the pump by the respective company or respective educator, and then they are doing really phenomenally good. So I can just exemplify one of my patients whom I've started on insulin pump in 2011, if I remember rightly, and that patient had CKD which was worsening at that time. And today I still follow this patient up. He is stable CKD, not worsening, is improving in all his complications. He knows how to handle his pump, even though he stays in one of the remotest area of Maharashtra. So I think that it's a matter of how a patient feels at ease while using a pump, which makes a lot of difference. And how it's like I tell my patients that if you have a dead phone and Apple phone, you just keep on table and do not use the features in it, you're not going to get the benefit of
Yeah,
it. So same is true
absolutely.
for pumps, that you need to know
Yes,
every feature which can benefit your glycemic control for that.
yes,
So I think I'll just add to that saying
yeah.
that with the pump, the involvement of the patient is the maximum actually. If you
Mm.
compare to any technology, the more the patient involves with the pump, then only they are able to achieve the best benefits. Although the benefits are huge, but not everybody who's using a pump gets that. I've seen patients who are on this latest device, the 780G as we call it.
Mm.
They are also not on control. Although I mean, everybody reports that they get good control, but there are a couple of patients. One patient
Yeah,
who I've seen who didn't want to actually get involved at all, and they don't see the benefit at all with that. So I think it's
true.
it's more of the involvement of the patient which is very important.
That's right.
Absolutely. So let's turn our attention to a different aspect of technology. So let's look at complications of diabetes. So can technology help in earlier detection of complications? Let's say neuropathy, Dr. Rakesh Sahai.
Yeah, I think technology is actually becoming very important in early detection of complications. When you look at neuropathy, you've got devices like the pseudo scan, which can pick up the early neuropathy signs, and then we have the confocal corneal microscopy, which is again another useful instrument which can pick up very early neuropathy, because we know that all these complications of diabetes are preventable. If you're picking up early, you can focus a little more on these complications and prevent the progression of these complications.
But
Similarly,
are
with the
are,
with
are are these standard
these are not standard.
clinical?
Yeah,
Yeah,
I
yeah,
don't think these are not the standard ones, but
right.
I mean, if we are
Not
speaking
yet.
about technology, that's not
Yeah,
yet come
yeah,
in, but
yeah.
that's what can come in the future. But I think there's nothing to replace the standard,
Hmm.
tune. I mean, the tuning fork and the monofilament, which actually makes it very useful in picking up neuropathy. And then we have the fundus cameras. I think more useful is more something which has actually come into practice is the fundus cameras, which are helping in early picking up of retinopathy, because that is again a complication which is often missed out till it becomes quite advanced, and that is a preventable cause of blindness. And I think
Right,
the fundus cameras have really made a bigger difference than the neuropathy devices
right,
as
right. Yeah, Sachin, would you like to dilate upon advances in screening for retinopathy? Please
Yes, sir.
unmute. Yeah.
Yes, yes. So as Dr. Sahib was highlighting, the fundus cameras are something which are, very, very helpful. We have all been using various types of fundus cameras. So it basically allows us to, take that image as a more like a point of care image at any time of the patient is there in the clinic. As the patient walks into the clinic, without the presence of an ophthalmologist, you dilate the eye and the image is transmitted. Now, there are two ways of interpreting that image. One is that based on their own data with which they have done an analysis and they have generated a report, which sometimes I find that the report accuracy is not as much there as you would want, but I guess that's a part of technology getting evolved. And the other way is that you can transmit that image to an ophthalmologist sitting remotely, more like a telemedicine, and that ophthalmologist can give an opinion based on the image of the fundus that you have transmitted, right? And
Right.
based on that, you can actually, give the diagnosis. So the patient actually is sitting in a diabetic clinic, and the ophthalmologist may be sitting in another part of the country, and the interpretation of the report is happening, and that actually has ramification in terms of bridging that urban rural divide also, because a lot of patients sitting in the places where you don't have that that kind of interpreting brains being able to go to a remote part of the country, but the device can always go there. And there have been instances, studies also, where people have done some camps and does that images on a bulk and then transmitted them, and that is where it has actually helped in terms of patient outcomes,
Right.
in terms of early detections.
Yes, and there have been AI being used for interpretation, as you were mentioning, of the retinal images. Now, one of the areas where I found, at least maybe a couple of years back, is that even the AI evaluation of the retinal images were not very uh, confident or accurate in distinguishing between a drusen and an exudate, or hard exudate or soft exudate. So, but of course, these must be getting better also, and I'm sure uh, this will be used much more often, and even in the absence of an ophthalmologist, possibly we will get equally valid interpretations. Can we ask Dr.
Right,
Vaishali
sir.
Deshmukh? Cardiovascular disease is one of the biggest killers in diabetes. So, where could technology come in to detect, to stratify cardiovascular disease risk in diabetes?
Yes, sir. So I think technology has helped a lot in early diagnosis of acute coronary events. We have tele-ECGs and technology where you have the cardiologist centrally located and he is able to diagnose the first event very easily with the tele-ECG communicated. So that I think we have already started with that in India. So India does have these centers where you can get a point of care of cardiac management immediately, even from the remotest area. So that's the easiest thing that has happened. But if you come to the latest in terms of advances, you do have endothelial dysfunction markers. So we know that endothelial dysfunction is something which is you can say a pre-stage of a cardiovascular disease. It's the earliest form of dysfunction of the vessel. So picking up endothelial dysfunction at that particular stage through technology has been one of the major advances, which a lot of experimental studies are using. We do use some in our clinical trials also. And you have, for example, you have flow mediated vasodilation
Good.
studies. Then we have the arterial tonometry, that is the resistance measure technologies. We have the heart rate variability devices, and we have all these technologies which aid us to identify these patients at the stage of microalbuminuria, at the stage of microvascular disease, and when they are progressing towards a macrovascular disease. So, if we are able to pick it up at that stage, I think we are able to prevent most of the macrovascular complications at an earlier stage. And even for that matter, the HEPF, that is the earlier part of heart failure evaluation with the BNP analysis and the assays that we are having in terms of evaluation. All these have helped us to identify heart failure in the stage where the ejection fraction has still not reduced. So I think a lot of things are coming in the way, and endothelial dysfunction, actually what is difficult for endothelial dysfunction is that we are not able to standardize it. We are not able to have a proper
Yeah,
guideline for it, or some drug strategy where if I identify, suppose, a endothelial dysfunction, what am I going to do? Am I going to start aspirin? Am I going to start a ACE inhibitor or a statin? That is the
yeah,
question in mind. So whenever technology is being used, we need to know as to what we are going to do with that report and the analysis. We need to have
sure.
some idea as to how to take it ahead.
Right. As we are sort of trying to come towards the end of this evening's exciting
Just one
discussion.
point I want to
Yes,
make.
yes,
So, as Dr. Vaishali already said, the point of care pro-BNP estimation is also very important. So, they are now coming, few companies are coming, they will do point of care pro-BNP level. If the pro-BNP level is high, particularly where you are suspecting incipient failure, a patient who is coming with diabetes with shortness of breath, but we are not sure that whether the patient should refer to cardiologist at earliest. In that case, if the pro-BNP level is gradually increasing, then it is better to admit the patient, or actually a close vigilance is necessary. So these are the most important point we can make it.
yeah, okay. And Dr. Sachin has already mentioned about apps which can help patients. So can you sort of tell us more about how we can suggest to patients to use of different apps for improving their care in diabetes?
Right. So the apps I would broadly classify into three categories. First is for the monitoring part. The monitoring part is for the data for the monitoring, right? So for instance, even glucometers have that app now where the Bluetooth enabled glucometers where the data actually instead of being recorded on a paper is getting recorded into that app, and the person's actually just shows the app actually reading of the glucometer readings, right? That's one simpler format to the apps like Libre Link, which are showing you, or the Libre View, which are showing you the data of the Libre sensor, or the Care Link, which is showing you the data of the Medtronic thing, right? For the glucose thing. Then there are apps for the even for the kind of bolus calculators, or basal calculator, or the insulin bolus dose adjuster, or the insulin dose adjustment apps, right? That are there. And then the apps are also there actually for reminder for medication reminder apps, right? Those also, since diabetic patients are on a lot of medications, it's also a very important part of the care of the patients. And then the last bit of apps is related with the food, nutrition, carbohydrate counting bit, which allows you to kind of make calculations based on the food you're eating, what kind of carbohydrate that are there. Then you can calculate what kind of insulin dosages that is needed, and then you can take care of that thing, do a better adjustment based on that. Nowadays, a lot of these things actually can be done using AI apps. For instance, if you can actually use an AI to use a algorithm to tell them that, okay, I'm eating this, my sensitivity factor is this, my carb ratio is this, what kind of a bolus dose I should take, right? And that AI will actually tell you that. So I think a lot of advances are already there, and a lot of advances will be there. Ma'am wants to say something. Dr. Vaishali,
Yeah.
ma'am wants to say something.
Yes.
Yeah, I think Dr. Sachin has mentioned a lot of apps, but because I'm involved with mind-body interventions, we're using a lot of apps for mind-body interventions and stress release and mental health of diabetic patients, and those which are helpful for improving their breathing capacity, their sarcopenia, their exercise capacity, a lot of food nutrition awareness apps. And I think these are apps which are like, it's difficult for us to educate people on these interventions on day-to-day basis, but these apps are wonderful in terms of patients practicing them. They are very easy to understand. They are irrespective of the languages, so they are just music based, which is understood by every population, and they're doing a wonderful job as far as their glycemic control, stress release, sleep quality, their weight loss, their muscle strength. And I think this is what we need to use as doctors, in addition to what we've been using as monitoring devices, or beyond glycemia, I would like to say.
Right. And these apps, are they costly?
So they are free apps. I
They are
have a
free
lot of
apps?
apps in my phone. I tell my
Hmm.
patient, this is the app you have to download, and
Yeah.
people are absolutely very happy.
Right. Great. So we talked about AI a number of times. So can we ask Dr. Ajit or Jitesh Rai as to the use of AI maybe for doctors for their scientific presentations? Do you use them? Please unmute yourself. Please unmute yourself. Not yet unmuted.
Yes.
Yeah.
Yeah. Okay. So actually, not yet totally, but yes, partially. I took help from AI,
So
and
is
I
that
think
helpful? Actually, did it help?
so. Yes, one important point is, suppose we had an idea and we have to structure it, then it is a very good step. We can go for this, but I think AI doesn't replace expertise; it just amplifies it. I can say that. So maybe they are giving some slides, but I have to change. And
Hmm.
sometimes what happens, some concepts it needs a diagram, but they will say that if this concept, if you go for diagram, then
Okay.
this
Yeah.
will be helpful. Some data needs a graph. So which data needs a graph and which data needs a diagram? That is a very
Hmm.
important aspect. I can say that we can get some help from AI, and
Right.
particularly which slides needs only one strong takeaway message. They will give you that this is a slide. You just give a strong takeaway message. So by that
Right.
way, we can say that we can get
Okay.
help.
Right. What about Vaishali or Sachin?
I use the Copilot very commonly for slide making, and it's a very good device because it saves on my time. So basically, yeah, I've seen that when
Ma'am,
I'm
what is the
sharing
what is the I just
Copilot.
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 Okay,
Microsoft
Copilot AI.
Copilot.
Yeah, it's
okay.
a very good app for making slides. Within 5 minutes, I have the structure of the presentation ready. Now, once the presentation structure is ready, I know what I have to talk to my audience. So I know my learning, my reading, my capacity. So it has saved a lot of my time. That's what I feel. That the presentations that I used to make 20 years before, it used to take the whole day, and now it's within 10 minutes I have the structure ready, and now I'm ready to present it with my own expertise added to it, with my own brains added to it. Instead of copying it, I have a format ready and I have a presentation which I can give with my clinical experience, and I can focus more on my experience rather than on the literature which is already there on the internet.
Yes, sir. I think I would agree with it. So how, we have been using it. I have been using it as, so like say for instance, I have to make a presentation, right? So I'll just tell that thing to give me a latest 2000 word review of this particular topic with all the latest articles published in last 1 year with their references. So they will the review will come with the references. It's almost like a review of literature of that last 1.5 year work with the because the basic concepts are already there. We already know the basic concepts, right? And then based on that, we just read it and just make our own ideas about it. Then you narrate a full story as to how I'm going to present it, and then actually you make the slides according to that. And a lot of times the slide making actually takes much lesser time compared to what otherwise would have been a situation like that. So the overall the quality of work actually has become better, and the input time has gone down.
So having
Right.
said that, if I can just add, I would
Yeah.
also say on this forum that you don't copy the AI. That is very
Yes,
important because I've seen a lot of hallucinations and abnormal wrong presentations with AI also. So I think every time you are going to the AI for help, see that you are also verifying it at your own end, because it is somebody else's brain that you are using, not your own brain.
that's true.
Yeah. So AI could be used in. I think there was complementarity to what Vaishali and Sachin said. So Vaishali and Dr. Ajit Roy spoke about getting a broad structure of what to say, what should be the plan of the presentation, and then Sachin also said that you can fill up those slides with specific information from what he said, a 2000 words sort of summary of what's the latest available. And of course, as Vaishali again pointed out, that we need to check on the details also, they can be misleading as well. So we come maybe to the last question, formal question here. Once again, for our audience, this is possibly the last time that you'll have these people on this forum to ask your queries. So can I ask Vaishali as to we all have been talking about AI taking over jobs, and how can we actually use AI to our advantage in running our clinics better? Maybe the diabetes clinic. Let's talk about diabetes clinic now.
So I personally feel that the only difference between the AI and the human brain is the wisdom. So the AI may give you knowledge, but it may not give you the wisdom to identify a particular abnormality in a patient, or may not give you a human touch or empathy and the human skills that are required for as a doctor or a practitioner. But having said that, I think the practice has been aided, supported, and also helped by AI. So we have seen that the appointments are made easy. We can give reminders. We can have their CGMS data on our screen. We can have them. I know the patient even before he lands into my clinic. So that's the kind of preparedness that we have. And the time has come down. Time for consultation has come down because I am already prepared with a plan. If I'm not prepared with a plan, the AI also gives me a plan. This would be a better plan for this particular type of patient. So I think you can say my brain has somewhat outsourcing done to AI, and that has saved my cognitive, you can say, load. So my brain is like preserved for a longer period of time because somebody's there to help me now. That's all I feel.
Right. Yeah. Great. So I think it was wonderful chatting with all of you, looking at some of the advances, the technological advances that may help diabetes care. And I've got a message on my screen that 1,765 doctors across the country had hooked on to listen to the discussions we're having. Clearly, meaning that doctors today are looking at technology, how best to use technology in their day-to-day clinical practice. We did have several areas covered, but there would be so many others that we didn't cover. But I think it was useful, and we would look forward to your suggestions for future episodes as well. So with these, I would profusely thank Professor Rakesh Sahai, Professor Jitesh Roy, Dr. Vaishali Deshmukh, Dr. Sachin Mittal, and all of you from across the country who all joined in and with your incisive questions and comments in the chat box that has made this program more lively. So it's over now to Dr. Prateek or the INTAS team for the concluding comments.
I think Dr. Ankit.
Okay, Dr. Ankit. Yeah, sure.
First of all, thanks to giving me the opportunity for vote of thanks, and I would like to thank you first, our wonderful speaker, Dr. Jitesh sir, Dr. Sachin, Dr. Vaishali ma'am, and Dr. Rakesh sir, and for the important topic about technology and innovation, how it helps to physician in day-to-day clinical practice. And also a special thanks to Dr. Subhankar sir, your constant support and the guidance for this whole series. You are the backbone of this Endocrine Talk Show series. And also, I would like to thank you to our participants. We have more than 700 participants who joined this program.
700 or 1700?
1700, so this
Yeah, okay.
So 1700 participants who joined this program. And also thank you for the technical team who constant support for this amazing program. This is all about that program, and
thank you.
Thank you. Thank you. I think we should
have
end.
a great weekend. Yes.
Yes. Just one particular thing written on Dr. Ajitesh Roy's wall behind him tells us what we should do. Even a Superman at the end needs to go to bed.
Yeah. Very important. Yeah. Thank you.
Yes.
Thank you, sir. Thank you, everyone. Thank you. Bye.
Thank
Thank
you.
you. Bye.
Good night.
Thank you, Dr.
Good
Ankit.
night. Good night.